As of mid-May 2026, international health agencies have pivoted their focus toward a developing cluster of hantavirus infections that has transitioned from a localized maritime incident into a complex global surveillance challenge. The primary focus of this investigation is the MV Hondius, a polar expedition cruise ship currently moored off the coast of Tenerife in the Canary Islands. While hantaviruses are traditionally viewed as stable, rodent-borne pathogens with limited geographic reach, recent mathematical modeling, summarized in the report titled The Last Breath, suggests that the current outbreak of the Andes virus strain represents a significant test for global biosecurity frameworks. The World Health Organization and the Centers for Disease Control and Prevention are now analyzing how a single point of exposure in South America has led to laboratory-confirmed cases and fatalities across multiple continents, including Europe and Africa. This report examines the intersection of mathematical predictive modeling and the ground-level reality of an emerging viral threat that defies the standard expectations of hantavirus behavior. The narrative began in early April 2026 when the MV Hondius departed from Ushuaia, Argentina, a known endemic region for the Andes virus. Unlike many other hantaviruses found in North America or Eurasia, the Andes virus variant is unique for its documented, albeit rare, ability to transmit directly between humans. This biological characteristic is at the heart of current public health concerns. Officials from the WHO, led by Director General Tedros Adhanom Ghebreyesus, have traveled to Spain to oversee the clinical management and evacuation of the ship's 147 passengers and crew, who represent 23 different nationalities. The framing of this event by senior virologists, such as Thomas G. Ciazek, suggests that while the risk of a full-scale pandemic remains statistically low, the vulnerability of international transit hubs like cruise ships and commercial ports to spillover events is higher than previously estimated. The mathematical models currently under review suggest that the spread of such pathogens is no longer restricted to the immediate vicinity of infected ports. Instead, these models indicate that the movement of asymptomatic carriers, individuals who are within the 4 to 6 week incubation period of the virus, can effectively bridge the gap between remote wilderness areas and major metropolitan centers. This last breath concept refers to the terminal stages of the infection where respiratory distress becomes severe. Yet the virus may have already been introduced to new environments days or weeks prior. As of May 12, the situation report indicates 11 total cases, with 9 laboratory confirmed as Andes virus and 3 confirmed deaths. The geography of the outbreak spans from the southern tip of Argentina to the South Atlantic Islands, and now into the clinical wards of South Africa and Western Europe, illustrating why this specific hantavirus cluster has triggered a Level 2 health alert. The core developments of this outbreak reveal a sophisticated logistical and diagnostic response involving multiple sovereign health ministries. The sequence of events accelerated on May 2, 2026. When the United Kingdom's International Health Regulations Focal Point notified the World Health Organization of a cluster of severe acute respiratory illness aboard the Dutch-flagged vessel. Surveillance data indicates the index case was an adult male who had spent 3 months traveling through Argentina, Chile, and Uruguay before boarding the ship on April 1. Investigators believe the primary exposure occurred during a bird-watching excursion near a landfill in Ushuaia, where the individual likely encountered aerosolized droppings or urine from infected long-tailed pygmy rice rats. Following his death on board on April 11, the virus appears to have moved through close contact networks within the ship's confined environment, a development that challenges the conventional understanding of hantavirus as a purely zoonotic threat. Clinical and laboratory responses have been distributed across several nations. One critically ill passenger was medically evacuated from Ascension Island to a specialized intensive care unit in Johannesburg, South Africa. It was here, on May 2, that polymerase chain reaction, or PCR, testing first confirmed the presence of hantavirus, followed by more detailed metagenomic sequencing that identified the Andes virus strain. Simultaneously, the European Centre for Disease Prevention and Control, or ECDC, began tracking passengers who had disembarked at previous stops, including St. Helena. This has led to the identification of symptomatic individuals in Zurich, Switzerland, and various locations in the Netherlands. The coordination between the Africa CDC and European health authorities highlights the lab-to-field pipeline required to manage a pathogen with such a high case fatality ratio, which currently sits at approximately 38% for this specific cluster. The role of the United States Centers for Disease Control and Prevention has also expanded as the ship reached the Canary Islands. A CDC team was dispatched to Tenerife to coordinate the repatriation of American citizens to a biocontainment facility in Nebraska, a move intended to ensure that any potential late-onset symptoms are managed under the strictest infection control protocols. This level of intervention is driven by the data provided by mathematical models which highlight infected ports as high-risk nodes. These models suggest that if a carrier disembarks at a major shipping hub, the probability of secondary and tertiary transmission chains increases exponentially if the virus is not identified within the first 48 hours of symptom onset. The contrast between the official statements, which emphasize that this is not a pandemic-level event, and the rigorous medical evacuations underscores the high degree of caution exercised by global health agencies when dealing with human-to-human hantavirus transmission. Prevention and ongoing surveillance efforts are now focused on breaking the chain of transmission and managing the significant uncertainties inherent in hantavirus pathology. Public health guidance remains centered on the elimination of rodent-to-human pathways in endemic areas. But for this specific cruise ship-linked event, the focus has shifted to clinical monitoring. Because hantavirus pulmonary syndrome, or HPS, can remain dormant for up to 42 days, the WHO has mandated that all passengers and crew from the MV Hondius remain under strict observation, even if they are currently asymptomatic. The prevention strategy emphasizes that individuals are generally only infectious while they are symptomatic, which provides a critical window for isolation and the implementation of standard and transmission-based precautions in healthcare settings. The limits of current medical knowledge are a central theme in the official briefings. There is currently no specific antiviral treatment or vaccine approved for the Andes virus. Clinical management is limited to aggressive supportive care, primarily consisting of mechanical ventilation and fluid management in intensive care units. The ECDC has noted that while the risk to the general European population remains very low, partly because the natural rodent reservoir for the Andes virus is not present in Europe, the risk to healthcare workers and close family members of the infected remains a primary concern. This has led to a call for increased pathogen literacy among clinicians, who are urged to include hantavirus in their diagnostic panels for patients presenting with sudden-onset respiratory distress and a history of recent international travel or maritime exposure. Looking forward, the global health community is utilizing the data from the MV Hondius outbreak to refine mathematical models for future surveillance. These models are designed to identify other high-risk itineraries where travelers might interact with remote ecological niches before returning to densely populated urban centers. The honest limit of current knowledge is that the full extent of the transmission on board the ship may not be known until the final incubation window closes in late June. Until then, the WHO and its partners will continue to monitor the status of the hospitalized patients in South Africa, the Netherlands, and Switzerland. As this episode of Global Health Reporting concludes, the focus remains on the vigilance of port authorities and the continued evolution of diagnostic tools to prevent a localized maritime cluster from becoming a broader public health crisis. Stay informed on these developing surveillance reports by subscribing to our updates. The operational response to the MV Hondius cluster accelerated on May 2, 2026, when the United Kingdom's International Health Regulations Focal Point formally notified the World Health Organization of a burgeoning respiratory crisis. By this stage, the vessel had become a floating laboratory for real-time epidemiological tracking. While the ship was positioned off the coast of Cape Verde, medical teams were already contending with a high case fatality ratio of approximately 38%. The clinical progression of the illness was described by health officials as rapid and severe, typically beginning with a febrile phase of high fever, myalgia, and gastrointestinal distress. before transitioning into acute respiratory distress syndrome and cardiogenic shock. The core development of this crisis centered on the logistical challenge of managing highly infectious patients in remote maritime environments. On April 27th, a male passenger presenting with worsening pneumonia was medically evacuated from Ascension Island to a specialized intensive care unit in Johannesburg, South Africa. It was within this facility that the National Institute for Communicable Diseases first utilized polymerase chain reaction testing to confirm the hantavirus presence, a finding that was later corroborated by metagenomic sequencing at the Geneva University hospitals in Switzerland. The diagnostic timeline proved critical for global surveillance. On May 6, the WHO confirmed the pathogen was the Andes virus strain, a development that shifted the international risk assessment due to the strain's unique potential for human-to-human transmission. This confirmation prompted the European Center for Disease Prevention and Control to initiate an expansive track and trace operation across multiple continents. The complexity of this last-breath transmission model is best illustrated by the case of a female passenger who disembarked at St. Helena on April 24th. Despite appearing stable upon departure, she deteriorated during a flight to South Africa and died upon arrival at a Johannesburg emergency department on April 26. This incident forced health agencies to contact every passenger on that specific flight, highlighting the vulnerability of international transit hubs to asymptomatic viral shedding. Simultaneously, a male passenger who had returned to Switzerland sought medical care in Zurich after developing symptoms, where he was immediately placed in isolation. The coordination between international agencies has been described by Maria van Kerkhove, the WHO's lead for epidemic and pandemic management, as a cautionary approach designed to prevent any opportunity for the virus to establish secondary transmission chains in non-endemic regions. As the MV Hondius reached Tenerife on May 10, Spanish health authorities, supported by a CDC team dispatched from the United States, began a tightly choreographed disembarkation process. The CDC's involvement focused heavily on the 17 American nationals on board, coordinating their transfer to a high-level biocontainment facility in Nebraska. This facility is equipped to handle the specialized supportive care required for hantavirus pulmonary syndrome, as no approved vaccine or specific antiviral treatment currently exists. The contrast between official rhetoric and operational reality is significant. While Dr. Tedros Adhanom Ghebreyesus has emphasized that this event is not another COVID, the implementation of 42-day mandatory monitoring periods and the use of dedicated repatriation flights with full respiratory protection for all passengers indicates that agencies are treating the Andes virus as a Tier 1 biosecurity threat in the laboratories. Scientists are now focusing on the viral load present in the respiratory secretions of the confirmed cases to determine the exact mechanism of transmission within the ship's enclosed spaces. The infected ports theory, posited by mathematical models, is being tested as investigators reconstruct the full travel itineraries of the 147 passengers and crew. Models suggest that the virus could theoretically have spread further had the outbreak not been identified while the ship was still in the Atlantic. Currently, at least 9 cases are laboratory confirmed, with surveillance continuing for the 23 different nationalities represented among the travelers. The UK Health Security Agency has confirmed that British nationals returning through Manchester are being monitored daily for fever and respiratory symptoms. This phase of the response remains a high-stakes exercise in clinical surveillance, where the data from South African and Swiss labs is being used to refine the predictive spread models that will govern future maritime health protocols. As of May 13, 2026, the primary public health directive following the MV Hondius incident is a rigorous adherence to a 42-day monitoring window, a duration mandated by the maximum known incubation period of the Andes virus strain. For the 147 passengers and crew as well as their primary contacts, the protocol remains a strictly observational wait-and-watch strategy. Public health guidance issued by the World Health Organization emphasizes that the most critical prevention measure is the early identification of symptoms, specifically the sudden onset of high fever, muscle aches in the large muscle groups, and unexplained fatigue. Because hantavirus pulmonary syndrome can mimic early-stage influenza, the official guidance for clinicians is to treat any history of travel to endemic South American regions or recent maritime transit as a high-priority diagnostic indicator. In practical terms, this means that for the next 6 weeks, global surveillance systems will remain at a state of heightened alert, searching for late-onset cases that could emerge in any of the 23 countries represented by the ship's manifest. The mechanisms of prevention for hantaviruses are grounded in the understanding of how these pathogens enter the human respiratory system. Generally accepted public health standards dictate that in areas where rodent reservoirs like the pygmy rice rat are present, the primary risk is the inhalation of aerosolized viral particles. Practical takeaways for travelers and residents in these regions include avoiding the stirring up of dust in enclosed spaces. Official recommendations advise against sweeping or vacuuming areas where rodent activity is suspected. Instead, surfaces should be thoroughly wetted with a 10% bleach solution to deactivate the virus before cleaning begins. However, the unique human-to-human transmission capability of the Andes virus adds a layer of complexity to these standard protocols. In hospital settings, prevention now involves the use of high-level respiratory protection, including N95 or FFP3 masks, and the placement of patients in negative pressure isolation rooms to prevent the accidental aerosolization of the virus during medical procedures like intubation. The honest limits of current medical knowledge remain a significant hurdle for health agencies. While mathematical models like the last breath provide a framework for predicting how a virus might move through global shipping lanes, these models are only as accurate as the data fed into them. There remains a deep uncertainty regarding the exact level of infectivity during the asymptomatic phase of the Andes virus. Currently, there is no FDA-approved or WHO pre-qualified vaccine for any hantavirus strain, nor is there a specific antiviral treatment that has proven universally effective in late-stage pulmonary syndrome. The reliance on supportive care, such as extracorporeal membrane oxygenation or ECMO, highlights the reality that once the last breath stage of respiratory failure is reached, medical intervention is a race against systemic collapse. This lack of a pharmaceutical silver bullet places the entire weight of the response on the speed of surveillance and the transparency of reporting by individual travelers and national health ministries. The ethical dimension of this reporting centers on the balance between public safety and the prevention of unnecessary panic or the stigmatization of international travelers. Health officials have emphasized that while the mortality rate is high for those infected, the virus does not possess the same high transmissibility characteristics as respiratory pathogens like measles or SARS-CoV-2. The ethical imperative for global health bodies is to maintain a state of measured transparency, providing enough data to keep clinicians alert without triggering the closure of essential trade and travel routes. As the investigation into the MV Hondius concludes its initial phase, the enduring lesson is the necessity of a unified global biosecurity framework that treats remote ports and luxury cruise ships with the same level of diagnostic scrutiny as major international airports. The calm closing of this chapter depends entirely on the continued vigilance of the global laboratory network over the coming weeks. For ongoing updates and deep dive reports on international public health surveillance, subscribe